Good morning, everyone. Today, our lecture is about urinary obstruction. And in this lecture, like there are many causes of urinary obstruction. For example, there is, uh, or you can say, retention, urinary obstruction or retention. For example, in the period after surgery, or you can say the post-operative period, there can be acute urinary retention. Then there is bladder, like the stones can obstruct the urine. So there are many causes. Of course, our next lecture is about urinary stones. So this lecture, we are going to talk about the very important thing which comes in urinary obstruction, or you can say the bladder outlet obstruction, and that is basically benign prostate hyperplasia. So basically, this lecture is about BPH. BPH is benign prostate hyperplasia. So you can say like BPH is basically the short form of or abbreviation of benign prostate hyperplasia. Now, to understand this condition, of course, the first thing which we must understand is the anatomy. As we already know that the urinary tract can be divided into the upper urinary tract and the lower urinary tract. So, of course, like prostate lies at the neck of the bladder. So, whenever there is urinary outflow obstruction, it is basically due to BPH or benign prostate hyperplasia. Of course, like it is the problem is with the lower urinary tract. The important thing to understand over here is that remember that prostate is just present in males, not in females. So, of course, like this lecture, which is about BPH, basically is about only the male patients. And now, one of the thing to important to mention here is, of course, whenever uh, like uh, we are dealing with urinary outflow obstruction, or benign prostate hyperplasia. If you will pay attention, benign means, of course, the tumors which don't spread, which don't metastasize, and prostate is the name of the organ, and hyperplasia is it's a pathological term in which like it become enlarged. Now the important thing to I will tell you, for example, as we are studying urinary obstruction, of course there is a if there is a stone over here or over here or over here, it can lead to a unilateral, what you can say, obstruction of the urine to flow in the bladder. So the kidney can present with hydronephrosis, but of course the urine will still come out because this kidney will keep on making urine. So of course, like BPH is a condition in which like this area is enlarged, so the patient may have a urinary obstruction. So now this one is a short classification about urinary obstruction, and as I told you, there could be lower and upper, and there could be one side upper urinary obstruction, there could be bilateral upper urinary obstruction, and for example, here they are showing you hydronephrosis or hydroureter, and of course, like when the obstruction is somewhere here. For example, there is a tumor in the bladder, and that basically closes this valve. So of course, like the fluid will start collecting here. There could be partial urinary obstruction, there could be complete urinary obstruction, and then one of the classification, there could be a congenital urinary obstruction, or there could be acquired urinary obstruction. So of course, prostate hyperplasia is a lower urinary tract, okay, which is bilateral, which is like can be partial, can be complete, which is a acquired one, and which could be acute and which could be chronic. So now, like these are all the causes which you can see of urinary tract obstruction. You can say, see uretropelvic junction obstruction, ectopic vessels, fiber bundle, stones, tuberculosis, tumors, nephroptosis, ureter orifice cyst, postcaval ureter, or ureteral inflammatory stenosis. So, of course, like here, there is a lot of causes are written over here, but we are basically discussing benign prostate hyperplasia. So you can see over here again, These are some figures to show you hydroureter, hydronephrosis. See, hydronephrosis. These are some of the images. So uh, wherever there is lower urinary tract obstruction, what can be our differential diagnosis? So it could be due to BPH, it could be due to prostate carcinoma, which will be our last lecture. It could be bladder neck fibrosis, it could be neck stenosis, it could be bladder tumor, it could be bladder or urethral stone or stones. Okay, so these are the differential diagnosis, or you can say different causes of urinary obstruction. Now, um, again, the causes of urinary tract obstruction continued. See, urethral benign and malignant neoplasms. Uh, okay, neurogenic bladder, bladder and ureter reflux, urethral stenosis. Remove this thing. Pelvic tumor extrusion or neurogenic bladder. So sorry, neurogenic bladder is also repeated, so that's fine. Okay, so all these causes are can lead to urinary retention. So of course, like whenever there is obstruction, pelvic pressure increases, GFR will be decreased, and urine and pelvis reflex like lymphatic vessels, pelvic veins, kidney matrix, and like of course what will happen, like due to all these things, that there will be renal parenchyma atrophy and collecting system dilatation. Okay, so for example, in this one, if you will see over here, of course, like kidneys will become enlarged, and again, like this is all the pathophysiology which they are showing, like there will be tube extension, and there will be hydronephrosis. Okay, so this will be the end result. So as we know, what is hydronephrosis? Hydronephrosis is like when there is too much collection of water or fluid inside the kidney, and these are the things which can occur due to that. So, in very simple words, if I will tell you, anyone who have hydronephrosis, right, what will happen to them is basically um, they will be having like the kidney. If you'll see over here, the kidney, all the functioning nephrons are over here. This is cortex and medulla. So of course, like due to hydronephrosis, when the fluid is exerting too much pressure on the kidney, see all the working units of the kidneys, there will be atrophy of that, and of course the kidney will stop functioning. So that's an important thing to remember about this condition. So now, of course, like anyone who have hydronephrosis, uh, what will happen, that they will be having a mass, like of course due to hydro like enlargement of the kidney, they may present with back pain or abdominal pain, and they can present with some other symptoms like fever frequency and dysuria. So anyhow, this one is the investigations which I will discuss later on with BPH. So now let's start discussing um, what you can say, uh, BPH. Like this one is a therapy for all the other things, right? Like as I told you that our main topic is basically uh, BPH, but of course, like for example, whatever the condition we will find, we are going to treat that. So if there are stones, we will remove that. If there is stenosis, we have to manage that. If there is polyp or tumor, remove that. If there is pressure from outside on the ureters or any structure, remove that. We can put ureter stents, and we can do percutaneous nephrostomy. Okay, so if the kidney is dysfunctional, so of course remove that. So uh, okay, the main thing to infer from all this discussion is simply there are many causes of uh, urinary tract obstruction, and whenever anyone have urinary tract obstruction, so we must have all the things in our mind which can cause urinary tract obstruction. And once we have diagnosed that, we have to treat that. Okay, so now we are going to go on our main topic, which is BPH. And what you can say, BPH is basically considered as the most common benign neoplasm of the adult male. Okay, and it is almost present in all the males or like with age. But the important thing to mention is like not all the males they have symptoms. So that's why we are only concerned, like we always treat the patients who basically have symptoms, right? But remember this thing, that BPH is so common, or it is so common tumor that it is present in almost all the adult males, right? So you can see over here, this is the normal prostate and this one is the enlarged prostate. Okay, so now you can see over here that adrenal glands and testicles, they produce testosterone, and testosterone they convert into androstenedione. And there's a drug which is there's an enzyme which is called as 5-alpha reductase, which convert testosterone to androstenedione. So why I'm telling you this thing, or why I like this enzyme is mentioned over here, you would get to know soon about this thing. So let's talk about anatomy, because anatomy is very important to understand in all the story. Okay. So what happens is like we can, uh, you can say, uh, divide, or we can classify or divide the prostate into these sections. If you can see over here, there is a peripheral zone, there is a central zone, and there is a transition zone, right? So basically peripheral zone is, you can say, basically mainly posterior, and this is the zone where most of the carcinomas can arise from. And then there is a central zone, which basically is behind the urethral meatus. Okay, and if you will see over here, the ejaculatory duct, it passes through both these zones, and it goes into the urethra. Okay, of course, like this is the urethra which is coming from the bladder. Now this one is the transition zone, right? So uh, now the important thing, that this transition zone is basically around the urethra, and this is the area where most of the benign prostatic hyperplasia they arises, right? So this peripheral zone, all the cancers, and this transition zone or the central zone, you can say, um, the BPH, okay, it get enlarged, it can get hypertrophic, or hyperplasia is there. So also, the prostate do have some smooth muscles in them. Okay, and if you can see over here, this is the bladder and this is the prostate, and how like they are linked together. Simply the urethra, they pass through the prostate. Okay, and what you can say, there is a special muscle over here which basically constrict or relax, of course, like that controls the ejaculation. So this is what you can say, a very general type of anatomy. So about prostate, and if you'll see over here again, they are showing you, see the relation of prostate with the rectum, with the bladder. There is seminal vesicles behind the bladder, which basically the ejaculatory duct, it goes, passes, and it opens over here in the urethra. And again, this is an anatomic photograph of the prostate. So uh, as I told you, that it is the transitional zone, like the zone which is around the urethra, where basically this changes started taking place, and the patient prostate become enlarged. And now, going further, you can say over here, okay, yes, prostate do have some muscles as well. Okay, or you can say um, what you can say uh, um, like the smooth muscles are there in the prostate. Okay, so now the important thing here is simply you can see that um, the pathology of benign prostate hyperplasia, the bladder muscle thickening and fiber tissue hyperplasia can be there, and prostate glandular hyperplasia can be there, or there could be bladder detrusor hyperplasia can be there. Okay, and what happens um, that once you can say um, okay, there is a lot of hormones, right, which basically act on the prostate. If you like, which I show you in the start, that 5 alpha reductase thing, which basically changed the testosterone to you can say dihydrotestosterone. Okay, uh, now uh, what happens in prostate, basically these hormones, these testosterone, or you can say the 1,5 dihydrotestosterone, or that is also we can write it by DHT. Basically these hormones are those which you can say which controls the growth of prostate. Okay, so what you can say, as we know that most of the testosterone which is produced inside the body is produced in the testes, right? And of course, like small quantities also produced in adrenal glands. So of course, uh, what you can say, once the testosterone is converted to 1,5 dihydrotestosterone and the enzyme is 5 alpha reductase. Okay, so that is what you can say, that is the basically the hormone which increases the growth of prostate. Okay, so you can say, like, the 5 dihydrotestosterone um, can increase the size of prostate, you can say uh, like it have more effect on prostate than the testosterone, or simply like it is 5 times more potent than the testosterone. Okay, now one of the thing which will come later on is basically a story about PSA. Okay, what is PSA? PSA is prostate specific antigen. Now, uh, this PSA have a lot of clinical importance. Why? Because PSA we check in the patients and people who have either prostate cancers or who have prostate hyperplasia, their PSA or prostate specific antigen levels are very high. Okay, so that is what you can say. Uh, like one of the thing which we check in these patients. Okay, and that guide us what you can say about or that can help in diagnosis and also in checking like like how the patient is responding to treatment, for example. Okay, so basically, what happens that um, what happens is, as I told you, that the hormone like testosterone or 1,5 dihydrotestosterone, it affects the person's prostate. Okay, and with age, the prostate, like everyone, prostate keep on enlarging. Some people do have symptoms, some people they don't have symptoms, right? um, so as we age, the testosterone level in the body, it get decreased. Okay, like if you are, when the male is young, they have more testosterone. When they become old, they have less testosterone. But all the estrogenic steroids in the body, um, they are also present, and their level basically don't decrease at the same level like the testosterone level decreases. Okay, so simply testosterone level decreases more than the estrogenic steroids which are present in the body. So now, again, it's a study or it's a theory, you can say. They say like the prostate get enlarged when there is imbalance between these two hormones. Okay. Okay. So one thing, by the way, which will come later on in this lecture, prostate hyperplasia is so common in adults, that they say that by the age of 60, around 60% of the patients, they do have BPH. They do have enlarged prostate. I'm just talking about enlarged prostate. I am not saying that they present with the signs and symptoms. Remember, uh, some of the patients, they present with signs and symptoms. Not all of the patients, they present with signs and symptoms. Rather, there are patients in which the prostate is enlarged, but they never get symptoms. Okay, so simply, uh, as I told you, again, the exact mechanism, like why the patient have benign prostatic hyperplasia, is not known, but like they say, it is due to imbalance of these two hormones. Okay, so simply, what happens is, there is proliferation of the cells in the transitional zone, this zone, and due to this proliferation, there is like they get enlarged, and once they get enlarged, simply uh, they press the urethra. Okay, so this is the main, what you can say, uh, main reason why people have outflow obstruction. Of course, when the urethra is compressed, the patient will not will be having sign and symptoms like urinary retention and things like this. Okay, one of the thing, um, anyone who have benign prostatic hyperplasia, basically how they present with the signs of um, bladder outflow obstruction, or you can say lower urinary tract symptoms. Okay, so basically in the books, what you will found two terms. One is called as LUTS and one is called as BOO. So what is LUTS? It is lower urinary tract symptoms. And what is BOO? BOO is bladder outflow or outlet obstruction. Okay, so simply you can see over here, the person, like normally when the patients urinate, the stream of urine goes like a lot further than this patient, how they are showing. Like he have retention, he have dribbling incontinence, he wet his trousers. Okay, so now, um, the important thing, like the thing to understand here is, whenever anyone have or patients have benign prostate hyperplasia, it doesn't means they will have symptoms. Most of the time, they don't have any symptoms, not at all. But sometimes they do present with symptoms of lower urinary tract symptoms, or obstruction, or sometimes they do have the symptoms of bladder outflow obstruction. Okay, so simply, they present with frequency, they present with dysuria, they present with retention of urine. Okay. Uh, Now, once the patient have benign prostatic hyperplasia, okay, and they present with symptoms, of course, it's very disturbing for the patients. Why? Because whenever they urinate, uh, they have to apply, put more force to urinate, and they have to go to, and even like after urinating, their bladder is not completely empty, and they have to go to the washroom, to the toilet, or to urinate again and again and again. And simply, this is like one of the thing. Okay, so now, um, like what happens in these patients, they have symptoms of, um, okay, Now there is some one term is called as urgency, one term is called as frequency, one term is called as hesitancy. Okay. Okay. So let me explain you these things. What is frequency? When you have to urinate again and again. What is urgency? That when you have to rush to the toilet to urinate, okay, otherwise it will started coming out. And what is hesitancy? That when you are urinating, it is uh, like the flow is not fine, right? So simply they have poor flow. They have like it's not like this, like when the normal person urinate, once the urine started coming out, so it keep on coming out until the bladder is empty. But what happens in them when they started urinating, the stream, like they urinate a little and then it stops, then they urinate a little and then it stops. So you can say like there is intermittent urination. Okay. And once they have finished urination, they have post void dribbling, like still the urinary drops, they keep on uh, coming out. And because they have blockage over here, they don't feel like their bladders are completely empty. So they go to urinate, they have hesitancy, they may have urgency, and once they urinate, their uh, stream is weak, and uh, they have like they urinate a little and then stop, and then urinate a little and then stop. And even after doing that, they don't feel like their bladder is empty. Okay. So these are basically, you can say like these symptoms are also called as voiding symptoms, like symptoms which come when you are urinating. And then there are some storage symptoms. Okay. What are storage symptoms? Basically they are more related to bladder. For example, uh, urgency is a storage symptom. What happens, by the way, whenever you have UTI, urinary tract infection, you have urgency as well. For example, um, uh, because of bladder irritation, suddenly the muscles go into contraction and you have to rush to the toilet, because, and this is called as urgency. So urgency is a storage symptom. Now, and sometimes there is urge incontinence. Okay, incontinence, like when when there is urine involuntarily, or when there is urination involuntarily. Okay. And sometimes there is nocturnal incontinence as well, like in the night they have dribbling of urine. Okay. So now uh, it's not always okay. So the patient can present with a combination of these symptoms plus some other symptoms. For example, they may have UTI, or they may have urinary tract infection symptoms. Sometimes they may have hematuria, and sometimes they do have incontinence, right? So simply, uh, like these are the symptoms. So you can say, again, I want to mention here, um, there is voiding symptoms. Okay. And what are the voiding symptoms? Hesitancy. Hesitancy is a voiding symptom. Poor flow or poor stream, dribbling, and sensation of uh, a sensation of uh, poor bladder um, emptying. Okay. And what are storage symptoms? Storage symptoms are basically frequency. Okay. There is urgency, and there is incontinence. Okay. And incontinence can be nocturnal, can be post voiding. Okay. Or urge incontinence, right? Can be there. So any one of these things can be there. Okay. So okay, these are the symptoms they present with. Okay, so how we diagnose? Okay, how we diagnose? Okay, and sometimes, for example, they have complete urinary retention. Complete urinary retention means what? They present to the hospital, their bladder is full, and the urine is not coming out. And of course, that is called as what? Bladder outflow obstruction. Okay, BOO, bladder outflow obstruction. I was talking about lower urinary tract symptoms, and BOO is bladder outflow obstruction. Of course, anyone who have BOO or bladder outflow obstruction, um, of course, like it means like there is uh, no urine at all. There is complete obstruction. There could be partial obstruction as well. Okay, so simply like these are two things which are there. Okay, so simply, basically, what happens in these patients? Anyone who have bladder outflow obstruction, like with time, uh, sorry, anyone who have BPH, uh, benign prostatic hyperplasia, with time, what happens that their bladder, because it is always full, okay, it is always full, so the bladder smooth muscles, they become unstable, okay, or you can say there is detrusor is the name of the muscle of the bladder, is detrusor instability. So uh, now, due to that detrusor instability, what happens is, the patient, like chronically, the patient may have bladder outflow obstruction. Okay, so um, uh, now what happens is, basically we go for some examinations plus investigations. I will tell you. Okay, what are the complications of BPH? Anyone who have BPH, they may have urinary infection, urinary calculi, stones, hydronephrosis. Their kidneys function can become impaired, and they may have inguinal hernia. These are the complications. So now, what we can do to diagnose these patients? Okay, this is of course, like everyone must know these things. Okay, what are the investigations to do? Okay, for example, you have a patient, especially like patient who are more than 50 years of age or 60 years of age, and one thing we know that uh, almost 60% of the patients at 60 years of age have BPH, right? So and not all of them they have symptoms, but whenever they have symptoms, the patient will come with the complaints of urinary frequency, urgency, weak stream, hesitancy, post void dribbling, urgent continence, and things like this. So, of course, there should be some list in your mind to uh, deal with this patient. So, you will be thinking about BPH, you will be thinking about prostate carcinoma, you will be thinking about tumors, you will be thinking about, for example, UTI. You can be thinking, maybe you can be thinking of diabetes. Who knows, right? Because diabetes, again, the patients, the patients complain like they have to urinate again and again and again. So of course, then you have to do some kind of investigations to reach the diagnosis. So one thing which can be done very quickly, as an office test, you can do a urinary dipstick. And you can simply rule out if the patient do have any UTI or not, right? So now, uh, what happens is, we do something called as urine flow studies, or you can say uroflowmetry, right? So in this one, what they see, uh, basically, uh, again, you can Google it or you can YouTube it, and you can find like how they do this test. Basically, they pass a catheter in the patient, okay, and after passing the catheter, they check the pressure changes of the bladder, and they check the pressure changes or which are formed by detrusor muscle, and they also, what you can say, check the urinary flow rates. Okay, so for example, um, uh, like a normal flow rate is any flow rate when it is more than 15 milliliter per second. Okay, and when the patient is voiding means like urinating, and he's urinating more than 200 milliliter of urine. Okay, so when the flow is decreased, okay, which is basically less than 10 milliliter per second, of course it means like there is poor flow. Okay, now one of the thing which they measure is also the volume, at which volume the person have sensation, at which volume, for example, the detrusor may contract. So of course, like they give the patient fluid in the bladder, and they check the what you can say, the pressure changes. Okay, now like this is basically urine uroflowmetry or urine flow test. Okay, so now the thing is that not all the patients they present with same features. For example, one of the patient, he can present with acute retention, he cannot urinate today, before he was fine. One patient is complaining that that he started having some sort of difficulty in urination like before 1 year, but now it is becoming worse and worse. Okay, so these things, so all the patients, they have different type of uh, what you can say, history. Okay, one of the thing, there is something called as IPSS. IPSS. Um, IPSS. What is IPSS? IPSS is basically International Prostate System Score, symptom score. Okay, so one of the thing, like on history, we can use a score sheet which is called as IPSS, and this one have basically um a questionnaire, you can say, in which like we ask the patient how much their life is disturbed due to this thing, uh, how much frequency problem they have, how much like at the night how much problem they have, and all these things. Okay, so IPSS scoring system can be used. So anyhow, simply we can go for that, and later on, of course, we go for examination. One of the very important examination which you will do is basically um, sorry, for here, after history, in examination, one of the very important examination is basically DRE. Okay, DRE. So what is DRE? DRE is basically digital rectal examination. Okay, so DRE is digital rectal examination. What they do, like they put a finger inside the rectum and they feel the prostate over there. So simply, I think you have done that thing in physical diagnostics, but like simply you have to check the surface of the prostate. You have to check like this, the rectal mucosa, either it's movable over the prostate or not. You can feel like if there is any nodules on the prostate or not. So you can go for DRE. So I was talking about, like, because like it's not written over here, but we have to discuss all the investigations. So what I told you, we can do urine examination. In that one, of course, we have to rule out UTI. Okay, we can go for DRE. Okay, we can do uroflowmetry. We can do ultrasonography. Okay, all these things can be checked. And one thing, of course, like if it is a chronic type, so you might be interested in doing RFTs, renal function testing. Okay, either there's any problem in the kidneys or not. Okay, so all these investigations we can do to diagnose BPH. Okay, so based on this results, we can say that the patient have benign prostate hyperplasia or not. One of the thing, okay, see, this is the test they are doing. I don't know how better you can see, but see, urodynamic studies they are doing. Of course, like there is a monitor in front of them, they are putting water. You can see over here, there is like the graph reading. They are putting the sterile water through the catheter inside the bladder, and these are they are checking the pressures also. Okay, also what are the pressure changes, and see, we get the readings like this. Okay, one of the things which we can check is PSA, prostate specific antigen. So prostate specific antigen, as you can see over here, it is the most sensitive tumor marker. The diagnosis source of prostate cancer, and what they do, by the way, of course, like not on the patient face it is written that he have benign prostatic hyperplasia, they may have cancer also. So this is one of the way to rule it out, or you can do a biopsy as well, but this is one of the way to rule it out. So like when the level is more than 4, it is, you can say, it is very much considered. Okay. Or you have to clinically correlate, like either you found any finding on bladder examination or not. So these are the tests which we can do. Then you can go for imaging. You can go for uh, like I told you, serum creatinine can be checked, right? Like the RFTs, renal function testing, of course, their serum creatinine can be checked. Okay, of course, like you can do cystoscopy to see inside the bladder. You can do CT scan, of course. So, of course, like we can do a lot of tests if you will talk like this way. So we can do a lot of tests. So simply, whenever you found that someone prostate is enlarged, the urodynamic studies will tell you, will show you, and you would understand that the patient have benign prostatic hyperplasia. So we have discussed this thing before, the differential diagnosis in the start. Okay, now how to treat the patient, this is the most important thing. First of all is emergency management. If anyone have acute retention, of course you are going to catheterize the patient and empty the bladder. That is the most important thing. Okay, but if anyone have chronic retention, or what you can say partial retention, you can think what to do. Okay, how this thing is managed. Okay, so there is conservative management is available. Here it is written watchful waiting. I usually say conservative management. Like, of course, like you can wait and watch and observe the patient. Then there are some drugs which are available, and then of course there is surgical treatment are there which are available, and then there are some other treatments which are available as well. Okay, now as I told you, if the patient is in emergency, the story is different. Okay. Okay, so now anyone who is coming uh, to the doctor, and you have to manage benign prostatic hyperplasia, uh, what we can do, we can put them on certain drugs. For example, one drug you can see alpha 1 receptor blockade can be done, or 5 alpha reductase inhibitors can be given. Okay. Okay, I will remove this one for this lecture because this one is not relevant. Okay, now as we know that alpha adrenergic block, alpha 1 or alpha receptors adrenergic blocking agents can be given, right? Basically, like they are alpha 1 or alpha 1A receptors, Okay. What is the function of this drug is basically, okay, these are the company names of the drugs. Basically, they relax the smooth muscles, right? Like alpha 1 receptor blockade, they relax the smooth muscles. Okay, so we can put the patient on these drugs. Okay, and how we can put the patient on these drugs, like, or when to put the patient in these drugs, um, simply alpha adrenergic blockers, or uh, 5 alpha reductase blockers, whatever you are using. One of the drug, the name of this one, alpha 1 receptor blockers, the name what you must remember is tamsulosin. Okay, and the one which is 5 alpha reductase inhibitors, um, like if you want to read it in pharma books, it will be finasteride. Okay, this is the name of the drug, the agent, you can say. So as we know, like 5 alpha 1 receptor blockers, uh, uh, they relax the smooth muscles in the prostate, right? And what 5 alpha reductase inhibitors do, they basically stop the conversion of testosterone to dihydrotestosterone. And as I told you, that dihydrotestosterone is more potent than testosterone, right? So now, any patient who will come, we can do watchful waiting if the symptoms are not so high, not so severe, not so disturbing. But we can tell them some measures, like limit the fluid intake before going to bed, uh, decrease take intake of coffee or tea, okay, because coffee or tea, they are diuretics. So most of the people, they drink coffee before going to bed, or in the evening time. So of course, in that case, there is more formation of urine, and of course, like, you feel more thirsty. So some fluid restriction with reduction in caffeine can be done. If cannot be managed that, then we can try these two drugs. Remember, alpha blockade or 5 alpha reductase. So alpha blockade, basically, tamsulosin, what they do, it block the receptors, um, uh, alpha and alpha 1a, okay, and that how it works. Now, any patient, of course, like, whenever these drugs are not working, okay, uh, and basically what these drugs do, they reduce the size of the prostate, okay, but it takes months, you can say sometimes up to 6 months, to reduce the size of the prostate. So these drugs do work, but we have to decide when to do that, okay, or like for how long, or either the patient needs, what you can say, emergency surgery or not. So when the medical therapy is not working, so of course we go for surgical therapy. For example, someone who have a very, very severe obstruction, okay, so you can see, like, anyone who have repeated urinary retention, repeated hematuria, residual urine volume of greater than 50 ml, repeated UTIs, bladder stones, or secondary upper urinary hydronephrosis, okay, or anything like this, of course we go for surgery. So what are the surgical options are there? Now, there are many. You can see over here some traditional procedures are written over here, like TERP, okay, uh, okay. Now, this all TERP and all these things, uh, they are you can say newer things. Of course, before, what they do is like open prostatectomy, okay, but nowadays, of course, we have special ways to do this thing, okay. You can see over a suprapubic transvesical prostatectomy can be done. Transurethral prostatectomy can be done. Transurethral, like, which is done through urethra. It is called as TURP. Transurethral incision of prostate can be done, which is TUIP. Transurethral plasma kinetic prostatectomy can be done. Laser therapy is available these days. And transurethral prostate enucleation can be done. Okay. So all these things are available nowadays, okay. Basically, uh, whenever we go for prostatectomy, we must tell the patient what are the complications of that, because many people after prostatectomy, they do have retrograde ejaculation, they may have erectile dysfunctions, okay, though the chances are less, but they may have, okay. So we must tell these two important things, because people, it's about their sexual life as well. So we always tell them this thing, okay. So uh, transurethral resection of prostate, of course, through urethra they go and they cut the prostate, okay, and that's how they do. And later on, they put, what you can say, some drainage for a few hours or few days, and then it is done. And of course, like suprapubic prostatectomy, it's a open surgery, they remove the prostate. Transvesical can be done, prostatectomy can be done, in which, what you can say, the bladder is like, it is approached through the bladder, okay. And all these things, of course, all these surgeries can be done. And as I told you, Nowadays, like some new procedures are also available. Laser therapy are available, or transurethral prostate enucleation is available as well. What are the what are the complications? This is written over here. Okay, sorry, this one is wrong spelling. Complications. Okay. Okay, so surgical procedures complications, of course, like as I told you, bleeding, hemorrhage it is what you can say, a complication of all the surgeries: bladder rupture, TRAV syndrome, urethral stricture, incontinence, male erectile dysfunction, right? Retrograde ejaculation. Retrograde ejaculation is very common. Male erectile dysfunction is not so common. Okay, so all these things can be done. Even, sorry, one of the things which is missing here is infection. Of course, like again, infection is the complication of almost all the surgeries. So all these things, all these complications can occur in these patients. Okay, and of course, like these should be, they should tell this thing to the patient beforehand, that these complications can be there. So okay, in other treatment, of course, like there is a lot of what you can say, other treatments which are also available. For example, uh, they can put stents. Sorry, they can put stents. Okay, so one of the thing which can be done, where is this thing? They can put stents. Okay, like urethral stents can be given. There is some other therapies which claim like they have benefits, but not proven. Okay, so they can be tried as well, not used. So that's all about prostate wait. Sorry. Okay, that's all about this one. Okay, and thank you so much for listening. I hope you understand.